previous class, we have discussed about the orthotic treatment, the vision therapy for various binocular vision anomalies. So today I'll be starting with like how to identify the different types of binocular vision anomalies. Okay, so what is the like how do we first identify the binocular vision anomalies? So basically, we calculate based on the AC by A ratio. So we basically calculate with the AC by A ratio. So once we get the AC by A ratio, so accordingly we can actually understand like what type of binocular vision anomaly. We can just have a notion like what type of binocular vision anomaly is it. Okay, so AC by A ratio, based on that. So AC by ratio, how to calculate, we have already discussed the gradient method and the other methods also. So IPD plus near foria minus distance foria into working distance in meter. So that is a basic way we do the AC by ratio calculation in an orthoptic evaluation. So if the AC by ratio, normally whatever AC by ratio we get is around 4 to 7:1. Okay, so 4:1 to 7:1. Okay, so before I discuss the functional anomalies, one thing I would like to share with you that for any kind of like whenever we are doing any kind of near work, okay, so what happens that time? Basically, the near triad or the near triad acts that the accommodation, convergence, and the pupillary constriction happens. All of us know about that. But whenever any near task is given, so what happens is first our convergence will be acting. Okay, so our convergence does not decline with the age. Our convergence does not decline with the age, but our accommodation does decline with age. So whatever my convergence reserve is right now, it will be there after 10 years, 20 years also, that will be there. Okay, so suppose any task is given, so first our fusional convergence reserve works. Fusional convergence reserve works means, suppose an object is coming very near to our eyes. So what will be acting that time? When an object is coming very near to our eyes, our positive fusional convergence will be acting. Okay, so before our accommodation is acting, first our positive fusional convergence will act. Okay, so positive fusional convergence, what it will do? It will like try to maintain the fusion as long as it is possible. Okay, so any object which is coming nearer to us, first our positive fusional convergence will work. Or any target if we are reading, okay, at 40 centimeter, 30 centimeter, whatever distance we are reading, so first our positive fusional convergence reserve will work. Okay, then only when the positive fusional, when the fusional convergence reserve will get exhausted, that time it will be the responsibility of accommodation to maintain the fusion and clear and single image. Okay, so any object which is near to us, our PFV will work first. Okay, so once the PFV gets exhausted, our accommodation will start working, and also along with accommodation, the accommodative convergence will be working. Okay, so similarly, when an object is going far away from us, okay, so what will happen? First our divergence reserve will work, that is my negative fusional convergence will work. Okay, so negative fusional convergence will work, and then only other parameters will work. So always any near or distance target, whenever we are fixating at any near or distance target, our fusional convergence reserve will work first. So please to remember that So that is the reason while testing the negative fusional versions and positive fusional versions with the help of step versions method or any other methods. So NFV PFV can also be measured with the help of smooth versions method. Okay. So all these things can be also done. So whatever it is, first our fusional versions reserve will work, and then only our accommodation will work. So that is the thing. So today we'll be discussing about how to identify which kind of anomaly, binocular vision anomaly is it. So straight away, if you get a so normal AC by ratio is around 4:1 to 7:1. Normally it is written in book, it is written as 3:1 to 5:1. So but in normal clinical findings in India, whatever we get is 4:1 to 7:1. Okay, so anything below 4:1 is a low AC by ratio, anything above 7:1 or 6:1 is a high AC by A ratio. So low AC by ratio we get in case of convergence insufficiency, in case of divergence insufficiency. We get a high AC by A ratio in case of convergence excess and divergence excess. Okay, so all insufficiencies, whatever we are getting, all insufficiencies are basically will have show a low AC by A ratio. So suppose whatever AC by ratio we are getting, we can keep in mind, yes, it can be, if it is a low one, yes, it can be due to any kind of insufficiency. If it is a high AC by ratio, it can be due to any kind of excess. That we have to keep in mind. So AC by A ratio gives us a very clear-cut idea about what kind of dysfunction it can be. Okay. Now, another thing, we can also get a normal AC by A ratio. So anything between 4 to 7:1. So normal AC by A ratio, in which cases we get? We get in case of fusional vergence dysfunction. Fusional vergence dysfunction also I'll discuss the case what is fusional vergence dysfunction, but also we get a normal AC by A ratio in case of basic exophoria and basic esophoria. So basic exophoria means if we do a cover test or we do a Maddox rod test and measure the amount of exophoria at distance and near, so both the distance and near exophoria will be same. So that is called a basic exophoria. Okay. So in basic exophoria, what is there? The distance and near exophoria both are same. Similarly, in case of basic esophoria, the amount of esophoria for distance and near, it will be same. Okay. What will happen in case of convergence insufficiency? Convergence insufficiency, the near exophoria will be greater than distance exophoria. What will happen in convergence excess? The near esophoria will be greater than distance esophoria, right? In case of divergence insufficiency, what will happen? Divergence insufficiency, that means the distance esophoria will be more than the near esophoria. Divergence excess, the distance exophoria will be more than the near exophoria. So basic these things we have to understand while diagnosing any case. Okay. So coming to symptoms of convergence insufficiency, there will be asthenopia, there will be intermittent blur and diplopia. Okay, there will be inability, burning and tearing. There will be burning and tearing. There will be inability to sustain and concentrate. What do you mean by sustain? Sustain means, see, you can converge. Okay, right? I'm reading at a 40 centimeter distance. I can see clearly those words. Okay, but after some time you feel tiredness in your eyes. Why this is happening? Because I cannot sustain my convergence for a longer duration. Yes, I do have convergence. If I am doing the NPC test, near point of convergence test, I'm getting around 6 to 7 centimeter. That means it is fine. Okay, but when I'm repeating the test, if the NPC is receding, right? So that means I cannot sustain the convergence for a longer duration of time. Why does this happen? This happens due to like lack of fusional vergence reserve. So what is a fusional vergence reserve? What is a fusional Vargas reserve basically? Fusional Vargas reserve means, so for like so for suppose for near for reading it near, I have a 35 diopter of positive fusional Vargas reserve. So anything that is lesser than 35 diopter demand, if the demand is lesser than 35 diopter, that means I should be able to converge and see, right? So my reserve is 35 diopter for near, right? So that is the thing. So whatever reserve is there, so there is a Shear's criterion and all that I'll discuss. So basically my reserve should be much greater than the demand, that we have to keep in mind. So for patients with convergence insufficiency or any other BV anomalies, basically Vargas anomalies, basically their fusional Vargas reserve is not proper. That is the reason they cannot sustain it for a longer duration. That is the thing. So the patient finds inability to sustain and concentrate. Words will move on page, it will get blur, it might get double. We find we may get very tired while reading, there will be sleepiness while reading. Okay, so that is the thing. In case of convergence insufficiency, what we are getting, those are the symptoms the patient will be telling to you. Okay, now coming to the signs. Okay, before discussing the signs, let me tell for Vargas anomalies how to measure the Vargas anomalies directly. We can measure the Vargas anomalies, whether it is a convergence or a divergence problem, the PFV and NFV. Directly we can measure the PFV and NFV from the stiff Vargas test, from the smooth Vargas test. Okay, smooth Vargas test I have not discussed. Also we can like measure it with the help of Vargas facility. So Vargas facility, we use a 3 prism base in and 12 prism base out prism, and we see like an accommodative flipper, right? What we have discussed, accommodative facility testing. We are testing like how many cycles per minute the patient can do in 1 minute, right? In 1 minute, how many cycles the patient can complete. Same way, the Vargas facility testing, we do it. Okay. So Vargas facility, the Vargas flippers you can get in Shankanetla, Chennai, you can get very like few hospitals where binocular vision therapy is practiced all over India. They have those Vargas flippers, and definitely they do it for the routine orthoptic evaluation. Okay. So 3 prism base in and 12 prism base out. Okay. So once we are placing the base in, so what will happen if we are placing a 3 prism base in front of your eyes? 3 prism base in, base is placed towards inside, so the image will move towards the apex, right? So your eyes need to your NFV, it is actually measuring your NFV. Now when you are keeping the 12 prism, so yes, you will feel a what will happen, you will feel a double vision, and then if you're blinking, and then you can make it clear very easily, because there is a disparities created with the placing 3 prism basin, right? And now with the negative fusional versions of your eyes, you are like fusing and trying to maintain the fusion and single and clear image. Okay, so once you're keeping the 3 prism basin, your NFV like your NFV is working, and then it is you are making the target single, right? Now you are flipping. The once the patient is telling that yes, single and clear, you are flipping. So flipping means you are keeping the 12 prism base out right now. So 12 prism base out, base is outside, so the image shifting will be towards the apex. So that means your eyes, if it is a straight position, your eyes need to move this way, right? So that means it is measuring your positive fusional Vargas. So this way, this is the Vargas facility testing. By Vargas facility testing also, directly we can measure the positive fusional Vargas and the negative fusional Vargas. Similarly, already we have discussed the step Vargas testing. Also, there is something called the smooth Vargas testing. With the relay prism, we do it. So relay prism, basically we relay prism, if we are having, we can do this test. So that is a smooth Vargas testing. Okay, so these are the direct measures, right? These are the direct measures of NFV and PFV, but there are other things which also measure your convergence. Okay, those are the indirect measures. Those are the indirect measures which also measures your convergence and divergence. So what are the indirect measures? That is your NRA-PR. NRA-PR is basically measuring your accommodation, right? Negative relative accommodation and positive relative accommodation. But NRA-PR is also giving you an idea. It is also an indirect measure of NFV-PFV. Now, how it is doing that, right? So I have already discussed that for seeing any near target, first my positive functional convergence reserve will work, and for seeing any distance target, my negative functional convergence reserve will work. So while measuring the NRA, negative relative accommodation means you're relaxing the accommodation. Okay, that means first my divergence will happen. So that is a indirect measure of negative relative accommodation, right? So my divergence is happening. So that is also measuring your NFV. And positive relative accommodation, that means it is stimulating the accommodation. So first the positive functional convergence will work, and then your accommodation will get stimulated. So that is the reason it is an indirect measure of the PRA. So what will happen? What will be the signs for a convergence insufficiency? There will be low AC by A ratio, what we have discussed earlier. AC by A ratio in case of any insufficiency, it will be low. High exophoria will be there, and intermittent exotropia for near will be there. Okay, so there will be a intermittent exotropia for near. Okay, NPC will be receded. If you do repeated measurement of near point of convergence, it will be definitely receded. Okay, reduced PFV, positive functional convergence, will be reduced, and NRA will be reduced. Okay, sorry, one thing I just missed out. NRA will be reduced. Why? Because see, NRA means your eyes are diverging, right? NRA means your eyes are diverging. So you are putting the plus lens in the trial frame in 0.25 steps, and your eyes are diverging, and you are actually what you are doing, your accommodation is getting relaxed. When you put the plus lenses, your accommodation is getting relaxed and your eyes are diverging. Okay, so maintain fusion. To maintain fusion, basically, while measuring the NRA, what will work? Your positive functional convergence will work. So I was wrong in the, like, when discussing. So basically, NRA is an indirect measurement of the positive functional convergence. Why? Because while doing the NRA test, you are putting plus lenses, your eyes are diverging like this. Okay, your eyes are diverging, and you have to maintain the straight vision to see it clear and single. So that's why, so if your eyes are going out like this, now you have to, like, with your positive functional convergence reserve, you have to make your eyes straight, okay, to see that image single and clear. So first your positive functional reserve will work, positive functional convergence reserve, then like your, it will be an indirect, it will be the measure of amount of accommodation that can be relaxed. So in case of convergence insufficiency, will get a reduced PFV, and also you will find a little abnormal NRA findings. Okay, there will be reduced convergence facility at near, that will be there in the step convergence test, in the convergence facility test. Definitely there will be a reduced convergence facility. Okay, there may be an intermittent suppression, there may be a low MEM value. Low MEM value means low MEM value. MEM value, the lag of a normal lag of accommodation is plus 0.5 to plus 0.75. So it will be a lower than that. So intermittent suppression, why it happens? Because in case of convergence insufficiency, basically we see those patients with an intermittent exotropia for near. So like always there is no exotropia, but while they're seeing at near, or when their eyes are very tired, one eye is going out. So an intermittent exotropia for near is there. So to fight that intermittent exotropia, there may be an intermittent suppression. Okay. So one maybe the right eye is suppressed once, another time the left eye is suppressed one. Okay, alternate suppression also can be there. So that is the case in case of convergence insufficiency. Now we'll come to divergence insufficiency. Okay, divergence insufficiency. The divergence insufficiency coming to the symptoms. Divergence insufficiency means the patient while looking at distance, okay, and while looking at distance, see, this is my straight gaze. So when I'll be looking at near, it should be converged like this. My eyes should be converged like this, right? Now, when I'm looking at distance, my eyes should diverge like this. Okay, that means the eyes will not go out like this, but still, like you should have a normal divergence while looking at distance. So in case of divergence insufficiency, what the patient is having? The patient cannot diverge his eyes while looking at distance. Why does it happen? Because the patient might have a esophoria. More esophoria for distance the patient may have. Okay. May have an esotropia. Okay, so in case of congenital esotropia, also the patient might have a divergence insufficiency. So basically, the distance esophoria is more than the near esophoria. The patient will come with a, you can see those patients, they will be more, mostly they will be having a hyperopic correction. They might have a latent hyperopia. Okay, when we are doing a retinoscopy, you can find it. You can find that the patient might have a +1, +125, maybe accepting a +0.25 or +0.5, like that you can get it. Those patients come with divergence insufficiency. So patients main complaint what it will be, asthenopia more for distance task. Okay, there will be asthenopia for distance task. Okay, so while reading, the patient is not having any problem. He can concentrate and read and all. While looking at distance, he is having headache and all those sorts. While driving, the patient will have too much of problem, because while he cannot see those distance vehicles and all these things. Okay, he can have an intermittent blur. Sometimes blur will be there, sometimes diplopia at distance, and generally worse at the end of the day. Why? Because first my Vargas reserve, fusional Vargas reserve will work. My fusional Vargas reserve is working. It is getting tired at the end of the day. That happens in case of convergence and divergence insufficiency. So that is the thing. So in case of divergence, what will happen? My negative fusional Vargas reserve will work. So I have this much, only this much amount of NFP. Okay. So it is working, and it is getting tired at the end of the day. So the patient will feel sleepy. Okay, suppose a patient is like attending a conference, is seeing a presentation at distance. Okay, he will find very sleepy while seeing those slides at distance. Okay, it can happen. Or up after like half an hour or 1 hour of attending the conference, he will feel very tired. His eyes are very tired. That he will feel. Okay, so why? Because he cannot see, for like he has a divergence insufficiency. So coming to the signs of divergence insufficiency, so there will be a low AC by A ratio. Definitely. Why low AC by A ratio? Because in all insufficiency we'll have a low AC by A ratio. Esophoria more for distance, definitely will get a more esophoria for distance. The amount of esophoria, if you are measuring with the Maddox rod test, I'll also discuss about the Thorington's method of measuring the phoria. That is very important. That happens, this Thorington method, we can do it very like quickly, we can measure it. Okay, I'll discuss it later. So we'll find a esophoria more for distance. We'll also get a reduced negative fusional Vargas and Vargas facility with basin and distance. So basin prisms, what we are measuring the negative fusional Vargas. So distance, like basin for near, it is normal, we can get it normal, but basin for distance will get a reduced value in case of divergence insufficiency. So these are the signs of divergence insufficiency. So is it clear to all of you? Any doubt? Any doubt till this? Yes. Any doubt till this? Yes. So all the insufficiency part we have completed. Now we'll come to excess. So what will happen in case of convergence excess? Any questions? Anyone? Any questions do you have? Yes. Okay. So coming to convergence excess. So convergence excess, when does it happen? Convergence excess means the patient might have a esotropia at near. Okay, the patient may be having a congenital esotropia. Okay, so that is the case. So in that case, the patient will over convert. So that is the convergence excess. So what will the patients complain? Asthenopia will be there definitely while reading, and while reading the books or any kind of near task, the patient will have headaches, the asthenopic symptoms, will have burning or tearing, you will be inability to sustain and concentrate. Okay, so like if we see it very superficially, signs of convergence in symptoms of convergence excess and convergence insufficiency may look like same, because the patient is having asthenopia, headache, burning, tearing, inability to sustain and concentrate while reading. Okay, so while we'll be measuring, like we'll be doing a proper orthoptic evaluation, then we'll find out the signs. In the case of the signs, we can find it out. So by the signs, if we can find it out, then we can find it is, yes, it is not a convergence insufficiency, it is an excess case. So in convergence excess, there will be a high AC by A ratio. Okay, E is at near. E is at near means esotropia at near or esophoria at near. Okay, so near esophoria will be much greater than the distance esophoria. So what is the difference with divergence insufficiency and convergence excess? For divergence insufficiency, the distance esophoria is more than near, and for convergence excess, the near esophoria is more than distant. The patient can have esotropia also for near. Okay, you can see the child crossing his eyes. Okay, you can see crossing his eyes, you can find it while reading. Okay, so that is a science main sign of convergence excess. The patient will have a reduced negative functional versions and a low PRA. Okay, negative functional versions will be reduced and a low PRA. So how the PRA is associated with negative functional versions? Yes. We have already discussed that. See, PRA is an indirect measurement of NMP, and NR is an indirect measurement of PFV. How? See, in case of PRA testing, that is the positive relative accommodation testing, what we are doing, we are putting the minus lenses in 0.25 steps. In the trial frame binocularly, we are putting the minus lenses you are putting. Okay, so 10 minutes we have in our hand, so 9 minutes almost we have in our hand. So we'll be discussing whatever is possible today, and then we'll continue in the next class. So what is happening in case of positive relative accommodation? We are putting in minus lenses binocularly, right? So it is actually stimulating your accommodation. So minus lenses, when you are putting in front of your eyes, what is happening? Your eyes are getting like this. Your eyes are like forced to stimulate the accommodation. Why? Because the target needs to be clear and single. The target cannot be blurred. When the target becomes blur, the first sustained blur, that is the end point of positive relative accommodation, right? So the target needs to be clear and single. So when we are putting the minus lens on the trial frame, okay, your eyes were straight. You're reading. Okay, you are putting the minus lenses. You're increasing the difficulty level. So from the straight position, your eyes will accommodation will be stimulated, and the demand is increasing when you are putting those minus lenses more and more, right? Now, if you have to see it clear and single, if your eyes are forced to, your eyes are straight. If your eyes are forced to come like this, to see it single and clear, your eyes must go this way. Okay. So by putting those lenses, you're forcing your eyes to like move in this direction. Now you have to do an ulta, like any opposite reaction to maintain the clear and single binocular vision. So that is the reason your negative fusional vergence will work. Your negative fusional vergence will work during positive relative accommodation testing. First, your negative fusional vergence reserve will be exhausted. Then your accommodative component will get exhausted. Clear to all of you? First, your fusional vergence reserve works, then your accommodative component works. Okay. So whenever we are doing any kind of testing at near or distance, first our fusional vergence reserve will work, then our accommodative component will work. So first your NFV will get exhausted. After that only your accommodation will now try, okay, will now try to maintain the clear image. Okay, but when the accommodative reserve gets exhausted, you will get a first sustained blur. That is a measurement of positive relative accommodation. So indirectly it is a measure of your negative fusional vergence. So in convergence excess, will get a reduced NFV. Definitely will be getting a reduced NFV, and along with that you can get a low PRA value also. Is it clear to all of you? Yes. Any questions? Any questions? Okay. Also, so there will be a reduced NFV and low PRA value. Also, there will be reduced vergence facility at near. So in the step vergence test, you will get a reduced NFV. So reduced NFV means your basin prisms, basin for near will be low. Basically, your basin for near will be low. There will be a high MEM value also. Okay. Now, so when you are, so for your exam purpose, if you are like trying to remember the clinical features of this disease, these binocular vision anomalies, see, for any anomaly, for any binocular vision anomaly, you do not need to mug up. You do not need to mug up the symptoms and signs. Just use your brain, just use your basic sense, and you can find it out. Because this is the case, so what can be the problem? Where may be the problem lying? Symptoms will be almost same for all the BV anomalies. Signs will be different. Okay, so you need not to mug up for anything for this binocular vision anomalies. Only thing you have to use your brain and use your basic basic sense, that will give you all the answers. Okay, so this is about the signs and symptoms of convergence excess. Also, the patient comes up with a intermittent esotropia at near, or the patient might have a congenital esotropia. Okay, so for near only the patient is having an esotropia, that can also happen. Or else if you're measuring the phoria with a Maddox rod or a Thorington's method, you will find that the near esophoria is always greater than the distance esophoria. At distance, the patient might not have any esophoria also. The patient may be orthophoria also at distance. But for near, definitely the esophoria or the esotropia will be much more in case of convergence excess. Okay. So this case we have discussed. Now we'll come to divergence excess, and then we'll close the class over here. So divergence excess, when does it happen? What are the symptoms? The patient will report to you that there is an outward deviation. The patient will not notice, maybe his friend or any family members have noticed that whenever the patient is looking at distance, his eyes are going outside. Okay, so our eyes needs to be straight like this. By looking at distances, one of the eyes are going outside. So that means there is a outward deviation in the case of divergence excess. For a child, what happens? The child will have a tendency to close one eye in bright light. If there is too much of light, the child cannot see properly. He will close one eye and he will feel better. So these are the symptoms in case of divergence excess. Also, the patient will have double vision at distance. Okay, because he is diverging too much. So that may be the problem. So these are the symptoms. Now coming to the signs of divergence excess. The patient reports with a greater exophoria or an intermittent divergence speed for distance. IDS means intermittent divergence speed. That means intermittent exotropia for distance. Means whenever the person is looking at distance, he is getting a exotropia at times, not all the times. Intermittent exotropia means intermittent divergence speed, or intermittent exotropia means exotropia is happening at times. Okay, sometimes there is exotropia, sometimes it is straight. So the patient may, when you are checking, we are doing the orthoptic evaluation, you will find that there is a greater exophoria for distance. Okay, and also there is an intermittent divergence speed for distance, or a intermittent divergence speed for distance. The patient completely normal whenever he is looking at you or looking at near or something, there is no problem. But whenever he is looking at distance, you are finding that sometimes is one of the eyes is going out. That is the thing. Or if you are measuring, you are doing a cover test, if you are doing a Maddox test or a Thorington test, you will find a more exophoria for distance. Normally they come with an IDS for distance. Okay, this is a excess case, divergence excess case. So definitely there will be a high AC by A ratio. That is for sure. Normally we get a high AC by A ratio. NPC will be normal. We check the near point of convergence. Subjectively and objectively, both will get normal. And there is an adequate positive fusional divergence also will be getting. So these are the signs of divergence excess. Okay, so any questions? We'll close the session over here. Please do. So we are already at the end of the session, so we'll be closing the session over here. So any questions till this? Yes. So how to differentiate between divergence excess and convergence insufficiency? Divergence excess, there will be the distance exophoria will be much greater than the near exophoria. In convergence insufficiency, the near exophoria will be much greater. Also in case of divergence excess, we'll get a IDS or an intermittent divergence speed for distance. So all these things will be there.